Hello, everybody. My name's Ed Pavlik. I'm welcoming you to GYN and GYN Garage. I'm here in Lexington, Kentucky. We have great weather. It's beautiful. It's in the low 80s, about 27 centigrade. My colleague today is Frank. What are you up to, Frank? What's the weather like?
It's pretty sweltering. London tends, well, I suspect England tends to stop really when the temperatures get to this. We are in the upper 80s, low 90s at the moment, and London is not built for this. But we're struggling on. I think the ice cream industry is doing well, and people must be buying an awful lot of swimming pools or mobile pools and things like that. We'll get there, and we know that in 2 or 3 days' time it'll return to the norm, which is a very nice sort of mid 70 Fahrenheit, with a bit of sunshine and a bit of rain, and it'll be fine. It always is.
So you don't expect any interruption of Wimbledon?
Uh, Interestingly, with the roof over the centre court and the number one court was designed to keep the rain off, and I think since it's been built, it's been more closed to keep the sun out. Or to keep the temperatures down. But of course, what happens is the humidity goes up dramatically. Um, I think Wimbledon always has the capacity for another 2 or 3 days. It's a 2 week event, as you know, but I think the Monday and Tuesday after the second week are always kept open just if we need to catch up.
I see. Well, today we're going to consider the question, is there increased intraoperative ovarian capsule rupture due to increased minimally invasive surgery? And is there an effect on survival? An answer to this question is approached in a paper titled Minimally Invasive Surgery, Intraoperative Capsule Rupture, and Survival in Early Ovarian Cancer. This paper was recently published in JAMA Oncology. Frank, give us your insights.
Okay, when I looked at the abstract when you sent it on Ed's list, and I thought that looks quite interesting. I was a little bit disappointed. In actual fact, it's only a letter with some data in. It's not a large paper, and I wondered at that time why it was written. One of the references is to an earlier paper by members of the same group, which was published in JAMA Oncology in 2020, and it looked at a very similar idea that increasing the use of minimal access or minimal incisional surgery, however it's defined, increases the risk of rupture, and does that lead to an increase in the risk of the development of cancer and survival? Well, of course it does. Otherwise, FIGO wouldn't have separated 1A and 1C, 1C being iatrogenic tumor rupture during surgery. So in a way, the answer is already there. Otherwise, it wouldn't appear in the FIGO staging. However, the original paper did suggest that the two things that were associated with intraoperative rupture was the size of the tumor and whether or not the disease was being removed by laparoscopic or robotic surgery versus open surgery. And essentially, that's what they showed. This letter is almost like a reminder saying, well, despite what we said, the use of minimal access surgery, laparoscopic or robotic, has increased over another study period. And it's gone up by something like 26%, or is around 26%, of which mainly is due to increase in robotic surgery. So this small letter suggests that the use of laparoscopic surgery has increased, and therefore the risk of rupture has increased. And they've got a 3.5 year survival, which actually shows that if there's capsular rupture with at minimal access surgery, then the 3.5 year survival is 92.6%, non-rupture 94.7%, open laparotomy with rupture 91%, open laparotomy without rupture 92%. And those survivals are pretty good. And I think certainly the curve on the right hand side, those two are almost one on top of the other. And also, it begs the question, what do you actually say to a patient when she is discussing the surgical options? And you say, well, actually, the 3.5 year overall survival are almost identical. I know statistically they may not be identical, but to a patient, I don't think there's a lot of difference between 92.6% and 91%. So I'm not even sure that it helps physicians or clinicians to determine what's the best approach, what's the best way. The other thing is, why does this happen? Why is there increase or a decrease in survival for laparoscopic tumor rupture, but not open laparotomy tumor rupture? And the authors have suggested that it's possibly the fact that the patient is in Trendelenburg for 3 hours or whatever the length of the surgery, which is possible. They question the use of upper abdominal packing and whether or not a pneumoperitoneum increases intra-abdominal pressure and therefore spreads the tumor from the capsule more quickly. And I'm not sure whether that's the case or not. It would have been nice, particularly when they've got data that goes back much more than from the big paper. What is the site of recurrence? If the site of recurrence was upper abdominal or peritoneal disease, then I could accept that with Trendelenburg, the fluid from the capsule being in the upper abdomen, I could accept that perhaps there is something behind that. But I don't think that they haven't answered that question. In addition, what about port site recurrence or port site disease? They don't mention that at all. The other thing, and this is slightly disturbing because they have so much data. There's nothing about when the tumor ruptured. Was it ruptured right at the beginning of surgery, or was it almost finished as it was being brought out of the abdomen when it ruptured? I think that might be important. How long was the peritoneum exposed to the contents of the ruptured cyst? Were there adhesions as well? Adhesions, we know that if adhesions are positive, it puts the disease into the FIGO 2 stage rather than FIGO 1. We also don't know the cause of death. The assumption is they all died of ovarian cancer, but there's nothing about the cause of death. And we don't know, of course, whether or not, particularly in view of the previous studies showing an increased risk in the disease in these women who have rupture, were they treated with chemotherapy, even though it's a stage 1C disease? So we don't really know an awful lot of the outcome. All we know is that you get an increased tumor rupture if you're using minimal access surgery. Then, of course, is how do you do the randomized study, which this one really must be calling out for. And I think it would be very difficult to speak to an experienced laparoscopic, a gynecological oncologist saying, what we want you to do is an open laparotomy. It's always been argued that one of the reasons why you cannot do such a huge study of debulking surgery is that you'd be asking a bunch of experienced gynecological oncologists not to do their maximum amount of surgery at first laparotomy. And I think you would not be able to carry out a study comparing the incidence of rupture along those lines. The thing to remember, of course, is that if we were talking about cervix cancer, then people would say, well, of course, look at the evidence that we can get the disease out laparoscopically, etc., etc. But along come the LAC study of a few years ago, which showed the inferior survival for patients who'd undergone radical hysterectomy under with laparoscopic surgery. And it would be awful, wouldn't it, if this was repeated? Here we are doing laparoscopic surgery. We think it might be or produce some harm in a number of patients, but we can't show it and we're not sure what to do with it.
Sure. I mean, I agree. The one other question I would raise is this is a U.S. study, and granted that robotic apparatuses or apparati are very available in this country, but still not every OR that in institutions that have robotics has a robot. And so what it boils down to is if you compare the preparation of a surgical suite for open surgery versus for the robotic surgery, it's both the room and the robot that need to be prepared. So what I'm getting at here is there's sort of pressure on people who are using the robot to not take too long. And I wonder when you have to irrigate, does it occur to you, or does a message come in from a hospital administrator watching over you that, well, you've washed enough, you've irrigated enough on this case where there's been a rupture and leakage. And, you know, the other thing is I wonder how effective the person's irrigation is when they're upside down as opposed to when they're not upside down.
Oh,
And
yeah, yeah.
that those are things that enter into it. But certainly you really wouldn't want to have those as variables that you planned in a randomized controlled study. Um, you know, yeah, I think anybody who was going to have surgery, only when they wake up do they feel that they might have been upside down because they have a headache or something like that. That you don't really want to talk about them ahead of time. Um, and anyway, we've done it again. Uh,
Yeah.
and hopefully we can do it again next month. Hopefully you cool off. That's the most. So
Yes, it'll be July by then, so we'll be going into autumn.
okay, you take care,
All
Frank.
right, Ed. Nice to see you. Take care.